Hi, I'm Jonathan Golub, and I'm an epidemiologist at the Johns Hopkins University Center for Tuberculosis Control. In the first talk, you heard about the global epidemiology and the global burden of tuberculosis. In this lecture, we will discuss the basic epidemiology of tuberculosis. So, let's get started. We'll start very simply in these first few slides, and much of this will likely be a review for many of you. What is tuberculosis? Tuberculosis is an infectious disease. It is caused by a bacterium called Mycobacterium tuberculosis, commonly referred to as the tubercle bacillus. Tuberculosis can damage the lungs, we often refer to that as pulmonary TB, or other parts of the body, and we refer to that as extrapulmonary tuberculosis. Tuberculosis is treatable with standard 4-drug therapy. It can be fatal, especially if not treated appropriately. There is preventive therapy available for people who are infected with Mycobacterium tuberculosis who have not yet developed active disease. There is also a vaccine available called BCG, or Bacillus Calmette-Guerin. The efficacy of BCG, however, is limited primarily to infants. You will hear quite a bit more about the therapy for tuberculosis, preventive therapy for tuberculosis, and the vaccine for TB later in this course. Now we'll discuss how tuberculosis is transmitted. Tuberculosis is very simply, it's transmitted from person to person. When a person with active tuberculosis coughs, sneezes, talks, sings, or even laughs, they expel the tubercle bacillus in tiny air droplets into the air, and these droplets can then be breathed in by somebody who comes into contact with them. So once a person who coughs them into the air is exposes other people to that air, that's when infection can occur, and the risk of this infection, of this transmission occurring, depends on the infectiousness of the patient, and we'll discuss this in more detail, but very simply, if an individual who has active disease has cavitary disease or smear-positive disease, that means they have much more bacilli in the body, and when they cough, that much more of the bacilli is expelled into the air. And the duration of exposure is also very important. If you have very brief exposure to a person with active disease, then you're very unlikely to become infected. However, if you have prolonged exposure, then your risk of becoming infected and breathing in the bacilli is much greater. Also, the environment is very important. If you're outside, your risk of being infected by a person with active disease is much lower than if you are in an inside environment where the air is very stagnant and there is very little change in the air from clean air and the air filled with the tubercle bacilli, and we'll discuss that in a little while. The reservoir of infection for tuberculosis is primarily humans, though there is some evidence that tuberculosis can be transmitted from cattle to human beings. However, virtually all transmission is person to person. One of the most important lessons for you to get from this talk is that tuberculosis is a two-stage process. The initial infection is with Mycobacterium tuberculosis is when a person breathes in the bacillus and becomes infected. For most people, that's the end of the story. They never progress to active disease, they never develop symptoms, and they remain healthy for the rest of their lives. However, for some people, and we'll learn about how many in a few minutes, progression from infection to disease occurs, and this is what we refer to as reactivation of tuberculosis. So now we'll go through the idea of the risk of TB infection and disease among exposed individuals. And I'll take you through a series of slides here to talk about some numbers, about your risk of becoming infected and your risk of progressing to active disease. So first, let's imagine that we are in a classroom, not a virtual classroom like we are right now, but if that all of you were in a classroom with me in a auditorium that's very small, so that there were approximately 100 of you, and I had active tuberculosis. And I was coughing, and I kept you in this room for a long period of time, and I was lecturing to you for a long period of time. Approximately 30 out of 100 of you, or 30%, would progress to approximately 30% of you would become infected with tuberculosis. Now you can see 70% of you, after prolonged close exposure, would remain uninfected. Now, as you see in this next part of this figure, the red box, you see that approximately 5 to 10% of you progress to active disease within the first 2 years of becoming infected. But the majority of you move on and contain the infection. Over your lifetime, approximately 5% of you will progress to active disease. But as you can see in the box at the bottom, approximately 85 to 90% of those 30% that became infected will actually progress to active disease. So a very small number of people among those who have become infected with Mycobacterium tuberculosis will actually progress to active disease. Now we will see how HIV greatly impacts these numbers. So what you see in the first part of this figure is the same that we saw in the last figure. 70% remain uninfected and 30% become infected. Now we are not sure, there is no strong evidence suggesting that HIV positive people are more likely to become infected when exposed to an active case of TB. However, we do suspect that that is the case. However, for this example, we will assume that 30% of you who are HIV infected will become infected with Mycobacterium tuberculosis. Now what we do see is that people who become infected, who are also infected with HIV, have a tremendously increased risk of progressing to active TB disease. As you see here, approximately 40% or more will progress to active disease within 2 years of becoming infected. Compare that to the HIV negatives who you saw in the previous slide, where 5 to 10% will progress to active disease within the first 2 years. So among those who do not progress to active disease in the first 2 years, they move on to the next blue box there, and you see that among those people, the risk of progressing to active disease per year is between 5 and 14%. So HIV-infected people who do not progress to active disease immediately, on average, 10% of them will progress to active disease each additional year. So you can see at the last box here, it says continued containment with a question mark. That is because if untreated, HIV-infected patients who are also infected with Mycobacterium tuberculosis will virtually all progress to active disease at some point in their lifetime. So this just emphasizes the tremendous impact that HIV has on TB infection, greatly increasing the risk of progressing to active disease. This is a table summarizing the differences between TB infection and TB disease. TB bacilli is present in the body in both people who are infected and people who have disease. However, as you can see in the second row here, the number of organisms is tremendously greater in people with active disease versus those with infection. A TB skin test is a way of determining whether or not a person is infected with Mycobacterium tuberculosis. You will hear more about that test later in a later lecture. People who are infected are usually positive on the skin test. People with active disease are usually positive as well. A chest radiograph, which is commonly used to diagnose TB, is always normal in a person who only has TB infection, but will always be abnormal in a person with active disease, especially those who have pulmonary TB. Now, when we look at sputum smear and sputum culture, these are the bacteriological tests used to diagnose TB, and you'll hear about them more in a later lecture. However, what's important to know here is that people who have infection, those people who are not sick, they just have latent tuberculosis infection, those people will be negative on a sputum smear or sputum culture. However, those with active disease, especially those with pulmonary disease, will most likely be sputum smear positive and should be sputum culture positive as well. Now, finally, those who are infected with latent tuberculosis do not have symptoms, and they are therefore not contagious or not infectious. However, those with TB disease, especially those with pulmonary disease, do have symptoms, most commonly, and they are also infectious, especially those who have pulmonary tuberculosis. However, it's important to note, and we'll mention this again later, that people who have active tuberculosis disease and start treatment, within the first 2 weeks of that treatment, they are no longer very infectious, and that is because the burden of the tuberculosis in their body has greatly declined. So finally, as a brief review of this first section, latent tuberculosis is an infection with Mycobacterium tuberculosis organisms that have been adequately contained by host defenses, but that retain the capacity to replicate and cause disease at a future date. Most HIV-negative people who are latently infected will never develop active tuberculosis disease. HIV infection dramatically increases the risk of developing active TB. The majority of TB cases, and you can see here we estimate this to be about 65 to 85%, arise from latent infection rather than recent transmission. And what this basically means is that the majority of cases of TB that develop come from people who have been infected with tuberculosis in the distant past, rather than those who have been infected very recently. We know this from molecular genotyping studies, where we were able to look at strains of tuberculosis in a population over time and see if people who have the same strains, if they have epidemiological evidence that they have been in contact with one another, then we know that that was recent transmission. But people who have individual strains that do not match anybody else's, we believe that they are from the distant past. And you will hear more about that in a lecture on molecular genotyping in this course. For the next part of this lecture, I'd like to talk about the risk factors for the various stages of tuberculosis. In this figure, you see the life cycle of tuberculosis. First, you see when a person becomes exposed. At some point in time, after that, they're infected. At some point in time after that, they progress to active disease. Some of them will progress directly to active tuberculosis, and this is what we refer to as primary tuberculosis. Others will remain in the latent tuberculosis stage for a prolonged period of time, and then eventually progress to active TB. Those who then progress to active TB will either be cured by treatment, or they will die. And among those who are cured, they can either have a recurrent TB event, which refers to either a relapse of their current TB, or a new infection with exogenous tuberculosis at a later date. Among those who recur, they can either be cured, or they can die. And then this part of the figure takes you through the various steps. So as I mentioned, a person at some point is exposed to TB, and then they can become infected, progress to active disease immediately, or progress to active disease from latent infection, either be cured or die, and recur, and if they recur, they can either be cured or die. So now we'd like to talk about the risk factors for Mycobacterium tuberculosis exposure. Now the risk factors for exposure and the risk factors for infection are quite similar. One of the most important is the prevalence of infectious TB in the environment that you are in. So if there are many people with tuberculosis, if you're in a very high prevalent, high incident area, then your risk of coming into contact with a person with active tuberculosis is considerably higher. And what also comes into play is your duration of exposure to a person who's infectious and the duration of infectiousness of an individual patient. So if I had tuberculosis and I did not seek treatment and I went about my business and went to work and went to various different environments, I would be putting many people at risk of becoming exposed to me and therefore becoming infected. The number of contacts with susceptible individuals per unit time of infectiousness. What we mean by this, very simply, is the level of crowding that is around an individual who has infectious TB. So if I'm living in the slums of Brazil with 7, 8, 9 people in a household and I have active TB, then I am putting many more people at risk than I am if I was living in a very rural environment, either by myself or with only one or two family members in a larger home. So it all depends on the environment and who you are putting at risk, and we refer to this as population density or how crowded an environment is. We also state here case demographics and cultural influences. A person who has active tuberculosis may act differently. An individual, a man, may be more likely to go out into society with their disease, while a woman may be more likely to stay at home while she's sick, or vice versa, depending on the cultural issues in a particular area. If a woman needs to work, she will continue to work while she's sick. Same thing with a man, and this can also differ by age groups. So the amount that an individual goes into society while they are sick can increase the risk of transmission, exposure, infection. So next we'll talk about the risk factors for infection, which are very similar to the risk factors for exposure that we just mentioned. We'll pay particular emphasis in this first part on the production of infectious particles. We mentioned that when a person with cavitary disease coughs, or with pulmonary disease coughs, or even or talks or sings, that they can expel a lot of TB bacilli into the air. Well, we'll talk about in a moment the importance of the size and the amount of tubercle bacilli that are expelled into the air. But also what's important is the site and type of disease. Cavitary patients are more likely to expel into the air and therefore are more infectious. And pulmonary patients, who are obviously cavitary as well, but also patients who are sputum smear positive and have a lot of bacilli inside, are more likely to expel into the air. We talk here about a lesion on the larynx. An individual who has laryngeal TB is very likely to expel many and small particles into the air. What you see here are the number of droplets produced by different activities. This was a very nice study done by Loudon in the 1960s in the US. And what you see first is the number of droplets that are produced by different activities, by coughing, by talking, and by singing. And you can see that when a person coughs, that is when the most droplet nuclei containing tubercle bacilli are expelled into the air. Next is talking, and very few bacilli are expelled when we sing. However, what you see in this next figure is that among the droplets that are expelled into the air when an individual sings, a much higher proportion, seen in red here, are actually very small in size. And it is these droplet nuclei that are very small in size that are the ones that are most likely to travel through the larynx, down into the lungs, and into the tiny air sacs called the alveoli, where infection starts to begin. And that is why we see some very interesting outbreaks among people with laryngeal TB who are actually singers, because when they sing, they can expel many small droplets into the air and expose people who are in their company. And we have seen here in Maryland, actually, several outbreaks of people in church choirs who had laryngeal TB, and upon singing, they expelled bacilli into the air, and the congregation was exposed, especially those in the first couple of rows. And later, when TB developed using molecular genotyping techniques, they were able to trace back and see that these individuals were infected from a person in the church choir. But what you see here is, although tubercle bacilli is expelled into the air when an individual talks, the majority of these tubercle bacilli, these droplets that are expelled into the air that hold the tubercle bacilli, are large and therefore unable to be breathed in by the individual who is exposed to them. Next, we'll talk about risk factors. We'll talk about more risk factors for infections, such as air clearance. And what we mean here is the volume of air in a room where an individual is coughing or talking or singing. And the exchange rate is very important. The more exchange that is going on, the more clean air that is coming in and taking the dirty air out, results in less exposure to the air with the tubercle bacilli. UV irradiation is a very effective way of reducing the exposure to to Mycobacterium tuberculosis. It's most useful in TB laboratories, where the tubercle bacilli is often in a TB hood, and therefore when the person is working on it, and tubercle bacilli that gets into the air is killed by the radiation. This is also starting to be used now in HIV clinics in South Africa and in other areas of the world. We mentioned that effective treatment of tuberculosis incredibly reduces the burden of TB very quickly, and therefore reduces the risk of transmission from an individual who is on therapy to others around them. And also we talked about host activities, and we talked about this in the sense of cultural activities, but this means that an individual who is infected, an individual who has active disease, depending on their activities, it increases or decreases their risk of transmitting disease to others. The severity of disease in the index case is very important. We mentioned that smear positivity increases infectiousness, and cavitation greatly increases infectiousness. And as Dr. George Comstock, who you'll hear about several times in this course, once told me, the cavity in the lung is heaven for a tubercle bacillus. The cavity has all the nutrients needed by the tubercle bacillus to thrive, and therefore it can replicate many times, and the burden of tuberculosis in cavitary patients is much higher than in non-cavitary patients, and therefore can result in more tubercle bacilli being transmitted. We mentioned the intensity and duration of contact, a measure of crowding, and poverty. And now what we often see is socioeconomic status is often the driving force for increased risk of tuberculosis infection and even tuberculosis disease. And primarily this is because in areas where there is a lot of poverty, people are in very close contact with one another, and therefore at tremendous risk of being exposed and infected when an individual among them has active tuberculosis. Now we'll talk about some risk factors for active TB, and we will combine risk factors for active TB among people who develop active TB from recent infection and those who develop active disease from latent infection. First, we'll talk about age. TB rates in the population are always highest in the very, very early ages, in the young babies, and they get reduced as a child gets older, often referred to as the golden years, between about 8 and 13 years of age, where the TB rates are at their lowest. However, you can see here in this graph, in this figure on the right, that TB rates peak again around the ages 19 to 22 and then decline as an individual ages. In India, the prevalence of TB among adult males is 2 to 4 times greater than females. Here you can see similar ratios in the United States. This is done in the United States in 2003, taking a look at the case rates by age. And you can see in the youngest age range, less than 15, the male to female ratio is just about 1. And if you went down to the younger ages, females would outweigh males a little bit. However, as age increases, the male to female ratio increases as well. And these similar ratios are seen throughout the world. We've discussed briefly that it's very important the time since infection. Your first 2 years after becoming infected are when you're at your greatest risk of progressing to active tuberculosis. You have a 10% lifetime risk of progressing to active disease after infection. However, it's important to note that this 10% lifetime risk is estimated among babies who have become recently infected. Therefore, we know that their lifetime risk is 10%. If you become infected for your first time at age 50, then your risk of progressing to active disease over your lifetime is less than 10%, probably in the range of 4 to 5%, though these numbers are all quite rough. Nutrition may factor into the development of active disease among people who are infected with latent tuberculosis. We are not exactly sure what the mechanisms are that may lead to active disease. Some speculate that vitamin D has an impact on increasing your risk of progressing to active disease if you have a vitamin D deficiency. However, the evidence for this is very suspect. There is certainly an interaction of poverty and malnutrition, and there's an association with thin body build. A lot of recent evidence and long-term evidence suggesting that people with lowest body mass index, a low BMI, are at increased risk of developing active TB, and also evidence suggesting that people who are overweight and even obese may be protected from developing active TB. And as George Comstock once said, tuberculosis may be the one disease where being fat is a good thing. Another risk factor for developing active disease is stress. And it seems that incidence increases with increasing stress levels. We've seen this quite a bit in immigrants who come into the United States who have already been infected with tuberculosis from their country before coming in. And when they arrived here within the first few years of arriving in the U.S., the stress of coming to a new country, trying to find a job, a place to live, and to survive has reactivated their latent infection, and they have developed tuberculosis. We know that their TB is not TB that they have picked up here in the United States, but it is TB that they acquired while they were in their original home country, and that is because we know this from genotyping their strains of tuberculosis and seeing that they do not match other people's strains that are here in the U.S. Now, the reason for stress increases the risk of active disease is likely due to the suppression of immunity. Stress can have a very significant impact on reducing your immunity. A couple of examples of looking at proxies for measuring stress. Here is an example from upstate New York in the early 1970s. And what we see here are the incidence rates of new cases of TB by socioeconomic level. And what the authors state here is that socioeconomic status is a good proxy for measuring a person's stress level. And people with the lowest socioeconomic status are assumed to be the most stressed, and as you can see here, they have the greatest rates of TB compared to those in the highest socioeconomic status who have very low rates of TB. And similar numbers are seen throughout the world. Another somewhat more interesting example is the incidence of pulmonary TB among males by marital status in Copenhagen, Denmark in the 1960s. And what you see here is that among people who are divorced and single, the rates of tuberculosis are the greatest, especially compared to those in the lowest line who are married. Now, of course, this suggests that being divorced is a proxy for stress. Now, I will leave it up to you to interpret whether being divorced or being married is a more stressful situation. But here we see that being divorced increases your risk of TB. Another risk factor for development of active TB is smoking. This is something that's been studied quite a bit in recent years, with 5 meta-analyses and literature reviews being published in just the last few years. There is a very strong association showing that current smoking increases your risk of developing active tuberculosis, and it increases your risk of recurrent tuberculosis. There is less evidence, but it is there, that suggests that smoking increases your risk of becoming infected with tuberculosis, and there's a growing body of evidence suggesting that smoking increases mortality among those with tuberculosis. In India, there have been 2 very recent papers that show that smokers are approximately 3 times as likely to develop pulmonary TB compared to non-smokers. And a very interesting paper that came out last year looking at smoking and mortality in general showed that 38% of deaths among 38% of deaths among male TB patients are attributable to smoking, and 9% among females. This is a huge number, and really suggesting the impact that smoking has on TB in India, and suggesting that if smoking cessation were to occur in great numbers, that possibly we could tremendously reduce the risk of TB and really reduce mortality due to TB. Finally, I'd like to end the risk factor section looking at risk factors for death from tuberculosis. One of the primary risk factors for mortality among TB patients is delays in seeking and receiving treatment. If an individual does not come in to seek treatment once they have symptoms of TB, then they are in the community for longer periods of time with greater risk of transmitting TB to others. And there is certainly social stigmatization that plays a role in this, and this is important in India as well, where often people do not want to be diagnosed with TB because of the social stigma attached to it, and therefore will delay presenting to their local healthcare centers and not get diagnosed with TB for prolonged periods of time, which will ultimately lead to greater risk of death. The site and form of TB we've discussed, but patients who have cavitary disease are most likely to die, more so than people with other forms of TB. Smoking, we've seen, increases your risk of mortality due to TB, and the most important contributor to death among patients with TB is HIV infection. And we'll talk about that quite a bit now. HIV is the leading infectious cause of death worldwide, and TB is the second leading infectious cause of death. Deaths from TB account for over 20% of the 2 million estimated HIV deaths annually. What you see here is a very simple model. Now this was made in the 1960s, and it was made using data from the United States, but it can be applicable to any situation. What you start with in the top left-hand side here is the pool of infected patients. So these are the people in the world who are, or in the population, who are infected, who have latent tuberculosis infection. In the world, we estimate that roughly to be about 1/3 of the population. In India, the most recent estimates are that approximately 10% of the population have latent tuberculosis infection. And as we mentioned, these people are at risk of progressing to active disease, and that's what we see in step 1. We see a proportion of the patients who are infected progress to active disease. These people who have active disease, labeled here as cases, then infect a proportion of the uninfected pool, which is what we see in the large rectangle on the bottom. Step 3A shows that these uninfected people then move up to the infected pool. Step 3B shows cases that develop very quickly, primary TB, that progress very quickly from infection to active disease, and then are at risk of exposing more of the uninfected and infecting them, and they would move up to the infected pool as well. It's a very simple model of tuberculosis, and which is why I showed it, because it can be applied to any situation. It doesn't have a lot of assumptions involved with it, which most models do, and you can put your own numbers in to figure out where the burden of tuberculosis in a particular population. Now I want to talk about briefly the impact of HIV on TB and how it affects that model that you just saw. HIV impairs cellular immunity and increases TB risk. When the person has TB infection, the cellular immune system has contained the illness, and therefore the person does not progress to active disease. Once HIV comes into the picture, cellular immunity is compromised, and TB is able to proliferate and reactivate. And you'll learn more about that in a later lecture. HIV-related TB is more likely to be smear-negative, extrapulmonary, and/or fatal. And therefore, smear-negative and extrapulmonary makes it much more difficult to diagnose HIV-related TB. HIV treatment can result in immune reconstitution disease or unmasking of TB. What this means very simply is that an HIV-infected patient starts receiving antiretroviral therapy. Once their immune system is bolstered and doing better, it starts to recognize that the person has active tuberculosis and starts to respond to that active tuberculosis, and then TB is diagnosed. You will hear quite a bit about immune reconstitution disease from one of the world's leaders in this illness later in the course as well. TB often is the first manifestation of HIV. And the reason that this is a problem is we are trying to diagnose TB and HIV, both of them, as quickly as possible. But many people, when they feel symptoms of TB, that is the first time that they come into a healthcare center and get diagnosed with TB, and therefore they get diagnosed with HIV at the same time. And this complicates treatment for both diseases. TB is associated with immune activation, higher viral load, and declining CD4 cell count. So basically, when an HIV-infected person starts to get sicker, their risk of TB increases. This summarizes some of the changing dynamics of TB due to HIV. The risk of acquiring tuberculosis infection, as I mentioned, We believe that it's greater in people who are HIV positive compared to those who are HIV negative, though there is no great evidence. Thus, I have the symbol there that I do. Risk of progressing to active disease, however, we know that HIV positive patients are at significantly greater risk of progressing to active disease compared to HIV negatives. The risk of transmitting the disease to others, however, on an individual level is not well documented. However, we do know, as we see in the bottom, that HIV positive patients are less likely to be sputum smear positive. And therefore, if they're more likely to be sputum smear negative, they have less bug and are less likely to transmit TB to others. Atypical chest radiograph is also more likely in HIV positive patients, making TB diagnosis more difficult. And the tuberculin skin test, which we briefly mentioned, but very simply, the tuberculin skin test is a measure of whether or not a person is infected with latent tuberculosis. And the test the sensitivity of the test is very poor in HIV negative patients, and it's even worse in HIV positive patients. So an HIV positive patient is much less likely to respond to the tuberculin skin test. So I won't go through all the steps again of this model, but what you see here in red is the addition of HIV to the model. The first model was done in the 1960s before HIV entered into the situation. But now you can see if you add HIV to the equation, it complicates matters quite a bit. These are some numbers you've probably heard, but TB-HIV killed nearly 500,000 people in 2007 worldwide, yet less than 1% of people living with HIV were screened for TB. Thus, expanding HIV testing is crucial for TB patients and also for patients with signs and symptoms of TB. Not enough HIV-infected patients are tested for TB, and not enough TB patients are tested for HIV. Traditionally, the way we try to control tuberculosis is to detect and treat the active cases of TB. If you find all of them who have active TB and you treat them well, then you will have significant impact in TB transmission because you will diagnose and treat the people who are at greatest risk of transmitting to others. However, this still leaves the pool of infected people who already are at risk of progressing to active disease. Thus, the second tenet of tuberculosis control is treatment of latent infection. However, very few countries in the world actually take part in this. And the third is vaccination. We briefly discussed BCG, and you'll learn more about it later in the course. It's the most widely used vaccination in the world. However, its efficacy is limited to babies and infants. So the WHO has adapted a new strategy called the 3I strategy for HIV-TB. And this refers to intensive or active and enhanced case finding. And what this means is going out into the community and finding TB. Right now, we rely on diagnosing TB by having individuals who feel sick come to a passive healthcare system and get diagnosed. So we have to rely on a person who has TB symptoms to come in, and then we have to rely on the system to diagnose them accurately. However, what the WHO is now recommending for HIV-related TB is to go into the community and try to find the TB earlier and therefore cut down on transmission by diagnosing and treating people earlier. Second is isoniazid preventive therapy. And you'll hear quite a bit about that later in the course, but this is a very effective way of treating people who have latent tuberculosis infection and reducing their risk of progressing to active disease. And finally, infection control, which is extremely important because much of TB transmission occurs within hospitals. When a person does come in with active TB, if they are not isolated properly, they put all the other individuals at great risk of becoming infected, and especially if they're HIV positive patients, these people are then at great risk of progressing to active disease. The Center for Tuberculosis Research here at Johns Hopkins has slightly adapted these control measures to very simply call it find TB, which is go out and find all the TB you can, and then treat TB, treat it appropriately, and hopefully with new drugs that are being developed, and prevent TB, give preventive therapy to those who are latently infected and greatly reduce their risk of progressing to active disease. Here's a simple model looking at the control strategies for TB. What you see here is a population of latent tuberculosis patients who, going down, look at the first down arrow there, will progress to active TB at some point. Among those who have active TB, they can expose and infect people who are uninfected, who then move up to the latent TB pool, and some of which progress quickly to primary TB. Treatment of TB acts at this step, and what you do here is you greatly reduce the risk of transmission by finding these people with active TB, hopefully earlier, and treating them appropriately and reducing their risk of transmitting TB. Next is vaccination. If you can vaccinate the uninfected population, then you protect them from becoming infected and developing active TB. TB preventive therapy reduces the risk of people who become infected with latent TB from progressing to primary TB or to active TB. And again, up here, as we mentioned, people who have latent TB who receive preventive therapy decrease their risk of progressing to active TB. So these are where the control strategies that we currently have in place can work, except for vaccination, which our vaccine is very limited only to infants. But if we did develop a good vaccine, this is where it would have its most effect. So finally, to conclude, what control of tuberculosis in the HIV era? What is wrong? Well, we haven't appropriately applied our existing tools. We do have tools to diagnose TB, but there's a lack of political will in many areas of the world to appropriately address the TB situation. There are also many weaknesses in the health systems that we cannot adequately use the tools that are currently available. And as you will learn about in this course, the existing tools that we do have are inadequate. They're a diagnostic test that miss many, many cases. The sputum smear test, which is what we use in most of the world, is only 50% sensitive in HIV negative patients, and even less so in HIV positive patients. Therefore, when we use this test and rely on this test, we are missing many of our TB cases. Adherence to regimens is very poor. So even though we have appropriate treatment for tuberculosis, 6 months of therapy that we currently have, it's very difficult for people to stay on this therapy and maintain it for 6 months. The current TB vaccine, as we mentioned, is not effective, and drug resistance worldwide is increasing and therefore complicating treatment. We desperately need new TB drugs, and several of which are in development, but it's been about 40 years since we've had a new drug introduced to the TB regimen. The HIV tremendously changes the epidemiologic situation, and it exploits all the weaknesses in our current TB control strategies. And most importantly, as I mentioned very briefly earlier, and you'll hear more about this, HIV and TB programs do not work together. HIV patients are not treated, or I'm sorry, HIV patients are not tested for TB, and TB patients are not tested for HIV. This relatively simple measure would greatly decrease the time that TB patients were able to be transmitting in their environment. So some strategies for controlling TB HIV are the Institute Collaborative TB HIV activities. Have the TB and HIV control programs work together. Improve case finding. Earlier detection of TB, earlier detection of HIV. Find people earlier in both of these diseases, and you will be better off at reducing the transmission that's occurring, increasing diagnosis, and greatly decreasing the burden of TB in HIV positive and HIV negative patients. Reduce morbidity and mortality among HIV-TB co-infected patients. Give HIV patients earlier treatment. We know that antiretroviral therapy reduces the risk of TB, but we need to give it to these patients earlier, and we need to give it to more patients. Cotrimoxazole for HIV-TB patients. This cuts down on other opportunistic infections and also decreases the risk of TB. And as we mentioned, antiretroviral therapy. And then preventive therapy. We have seen now through several studies that isoniazid preventive therapy and antiretroviral therapy together greatly reduce the risk of TB. And finally, infection control measures must be put into place. I'll end with two quotes. First, from Nelson Mandela back in July of 2004 at the Bangkok AIDS Conference. He said that the world has made defeating AIDS a top priority. This is a blessing, but TB remains ignored. Today we are calling on the world to recognize that we can't fight AIDS unless we do much more to fight TB as well. Nelson Mandela had TB. He recognized that HIV and TB together, at least in Africa where he was as having devastating effects on the population, and is having devastating effects worldwide as well. And I'll end with a quote from a New England Journal of Medicine article by a MD from India who is now living in the United States. And he said, in India, many people with tuberculosis continue to slip through the net and into jostling crowds, with at most a thin handkerchief to stifle their incessant coughs. And what this is very simply stating is that the healthcare system now in India and in many areas of the world is not adequate to appropriately diagnose TB and get people treated. We need to increase our diagnostic abilities with better tools and with better strategies to go and find people with active tuberculosis. And I'll end right there. Thank you.